Today, in this pharmacology lecture, we are focusing on antiarrhythmic drugs. We'll explore their mechanisms of action, therapeutic applications, and clinical relevance in detail. Make sure to check out our companion video, which includes a 10 MCQ quiz designed to test your understanding of antiarrhythmic pharmacology. The link is in the description below. Learning objectives. By the end of this video, you'll have a thorough understanding of the pathophysiology of cardiac arrhythmias and their impact on patient health. You'll learn the classification of antiarrhythmic drugs, including the von Willems system, and how these classes address different types of arrhythmias. You'll gain insight into the mechanisms of action of key antiarrhythmic agents, including their effects on cardiac ion channels, conduction pathways, and refractory periods. Additionally, you'll understand the pharmacokinetics of these drugs, such as their absorption, metabolism, and elimination. We'll also cover the side effects, adverse reactions, and contraindications of antiarrhythmic medications to help you identify potential risks in clinical practice. Finally, we'll touch on the latest advancements in antiarrhythmic therapy and their role in modern medicine. Now, let's transition to a detailed overview of arrhythmias, their types, and clinical features. Definition. Arrhythmias are abnormalities in the rate, rhythm, or conduction of electrical impulses in the heart. These irregularities can manifest as tachycardia, bradycardia, or fibrillation, leading to symptoms such as palpitations, fatigue, and syncope. Pathophysiologically, arrhythmias arise from disturbances in impulse formation or conduction within the heart, often triggered by ischemia, electrolyte imbalances, or structural heart disease. These disruptions can significantly impact quality of life, with severe cases leading to heart failure or even sudden cardiac death. Notably, cardiac arrhythmias are the primary cause of mortality in patients experiencing myocardial infarction or advanced heart failure. Irregular heart rhythms frequently manifest in association with conditions such as anesthesia, hyperthyroidism, and various electrolyte imbalances. Prevalence. Arrhythmias are remarkably prevalent, affecting millions globally. Their widespread occurrence places a significant strain on healthcare systems, making them a leading contributor to cardiovascular morbidity and mortality. Types of arrhythmias. There are four main types of arrhythmias, and these include bradyarrhythmias, where the heart beats too slowly, tachyarrhythmias, marked by an excessively rapid heart rate, supraventricular arrhythmias, which originate above the ventricles, and ventricular arrhythmias, arising from the lower chambers of the heart. The most prevalent type of arrhythmia is atrial fibrillation. Let's explore it in greater detail. Atrial fibrillation, or AF, is a common arrhythmia characterized by disorganized electrical impulses in the atria, leading to ineffective atrial contractions and irregular ventricular rates. This disrupts cardiac output, increasing stroke risk and systemic embolism. Atrial fibrillation may be paroxysmal, persistent, or permanent, progressing with age or underlying conditions. Symptoms range from palpitations and fatigue to dyspnea and syncope. Treatment goals for arrhythmias. The primary objectives of treating arrhythmias are to restore and maintain normal sinus rhythm, control ventricular rate, and prevent thromboembolic events. Other goals are immediate relief of symptoms like palpitations and chest discomfort, while long-term goals focus on reducing the risk of complications like stroke and heart failure. Treatment strategies aim to improve functional capacity, enhance the patient's quality of life, and minimize hospitalizations. Pharmacological therapy is pivotal in managing arrhythmias, targeting the underlying pathophysiology and alleviating symptoms. Medications play a role in controlling the electrical activity of the heart and preventing recurrence. These therapies are often combined with lifestyle modifications, catheter ablation, or surgical interventions for a comprehensive approach. Classification. Drugs used for arrhythmias are classified based on their electrophysiological effects and clinical utility. The von Willems classification categorizes antiarrhythmic drugs into four primary classes based on their mechanisms of action. The table presented here lists down these classes as shown. Class 1 agents, also called sodium channel blockers, are further subdivided into IA, such as quinidine, IB, like lidocaine, and IC, including flecainide. Class 2 agents consist of beta blockers, while Class 3 includes potassium channel blockers, and Class 4 comprises calcium channel blockers. A fifth category, Class V, covers miscellaneous agents. These classifications are based on how the drugs influence cardiac ion channels or autonomic regulation. Additionally, antiarrhythmic drugs can be grouped by their therapeutic roles, such as rate control or rhythm control agents. Rate control agents include metoprolol and diltiazem. Rhythm control agents include amiodarone and flecainide.
Although not part of the Vaughan-Williams system, anticoagulants play a vital role in minimizing stroke risk in conditions like atrial fibrillation. Here is another table that summarizes the Vaughan-Williams classes with key examples highlighted. Class 1 sodium channel blockers include quinidine, lidocaine, and flecainide, categorized by their varying degrees of sodium channel inhibition. Class 2 beta blockers, such as metoprolol, atenolol, and propranolol, reduce heart rate and contractility. Class 3 potassium channel blockers like amiodarone, dronedarone, and sotalol delay repolarization and prolong the QT interval. Class 4 calcium channel blockers, including verapamil, diltiazem, and amlodipine, slow conduction and heart rate. Class V miscellaneous agents, such as adenosine, digoxin, and magnesium, work through various mechanisms. While anticoagulants like warfarin, apixaban, and rivaroxaban prevent stroke and arrhythmias. Let's now look at the mechanisms of action and indications of the major drug subclasses used in the management of arrhythmias. Class 1 agents are sodium channel blockers. Sodium channel blockers act by inhibiting the rapid influx of sodium ions during phase 0 of the cardiac action potential, reducing the rate of depolarization in cardiac myocytes. This slows conduction velocity and decreases the likelihood of abnormal electrical impulses propagating through the heart, helping to prevent and terminate arrhythmias. These drugs are subdivided into Class 1A, 1B, and 1C agents. The table presented here presents these subclasses with their specific indications. Procainamide and quinidine, the Class 1A agents are used for atrial fibrillation. Lidocaine and mexiletine, Class 1B agents, are used for ventricular arrhythmias. Flecainide and propafenone, Class 1C agents are used for supraventricular tachycardias. These are some of the indications of Class 1 agents. Class 2 agents or beta-adrenergic blockers. Class 2 agents exert their effects by antagonizing beta-adrenergic receptors, leading to a decrease in cyclic AMP and inhibition of calcium influx during depolarization in pacemaker cells. This reduces heart rate, prolongs AV node conduction, and suppresses arrhythmogenic sympathetic stimulation, making them particularly effective in rate control. Common indications include the use of metoprolol and atenolol for managing atrial fibrillation and flutter, especially in patients with a history of ischemic heart disease or hypertension. Class 3 agents potassium channel blockers. Potassium channel blockers work by inhibiting the outward flow of potassium ions during phase 3 of the cardiac action potential, resulting in prolonged repolarization and refractory periods. This action helps prevent reentrant arrhythmias and maintain normal sinus rhythm. Amiodarone is a key example in this class, used for both atrial and ventricular arrhythmias due to its broad-spectrum antiarrhythmic properties, while sotalol is particularly useful for patients with life-threatening ventricular tachycardia. Class 4 agents or calcium channel blockers. Non-dihydropyridine calcium channel blockers, such as verapamil and diltiazem, inhibit L-type calcium channels, reducing calcium influx during phase 2 of the action potential in cardiac myocytes and nodal cells. This slows AV nodal conduction and decreases heart rate, making them effective for controlling ventricular rate in supraventricular tachyarrhythmias. Class 4 antiarrhythmics like verapamil are widely used to manage atrial fibrillation or atrial flutter. These agents are especially beneficial in patients where beta blockers are contraindicated, offering an effective alternative for rate control. Class V agents or miscellaneous agents. Class V agents, including adenosine and digoxin, operate through unique mechanisms to control arrhythmias. Adenosine briefly blocks AV node conduction by activating A1 adenosine receptors, making it highly effective for the acute termination of paroxysmal supraventricular tachycardia. Digoxin, on the other hand, increases vagal tone and reduces AV node conduction, making it beneficial for rate control in atrial fibrillation, particularly in patients with concomitant heart failure. These drug classes offer targeted mechanisms to address the underlying electrophysiological disturbances in arrhythmias, ensuring effective and tailored management for patients. Treatment guidelines. Clinical guidelines for managing arrhythmias emphasize the importance of stratifying treatment based on the type of arrhythmia, patient-specific factors, and overall clinical presentation. First-line treatments for atrial fibrillation, the most common arrhythmia, often include rate control with beta blockers such as bisoprolol, 2.5 to 5 mg once daily, or calcium channel blockers like diltiazem, 120 to 360 mg per day in divided doses. For rhythm control, antiarrhythmic agents such as flecainide, 50 to 200 mg twice daily, or amiodarone, 200 mg daily, are recommended, particularly in symptomatic patients or those with structural heart disease. In cases of ventricular arrhythmias, first-line treatment typically involves beta blockers, particularly metoprolol succinate, 50 to 100 mg daily,
to reduce the risk of sudden cardiac death. Amiodarone, 200 to 400 mg, daily is used to prolong action potential duration. For patients with life-threatening ventricular tachycardia or ventricular fibrillation, implantable cardioverter defibrillators, ICDs, are often combined with amiodarone to suppress recurrent arrhythmias. Individualization of treatment, such as adjusting doses or choosing alternative agents, is crucial in patients with renal or hepatic impairment.
Second-line treatments are considered when first-line options are contraindicated or ineffective.
For atrial fibrillation, digoxin, 125 to 250 micrograms once daily, may be used for rate control, especially in sedentary patients or those with heart failure. In refractory ventricular arrhythmias, sotalol, 80 to 160 mg twice daily, is sometimes employed for its dual beta blocking and antiarrhythmic effects, although it requires close monitoring due to proarrhythmic risks. Flecainide, 50 to 100 mg, can be used for supraventricular tachycardia but must be avoided in structural heart disease.
Pharmacokinetics, let's review the absorption, distribution, metabolism, and elimination of antiarrhythmic drugs. Absorption of antiarrhythmic drugs varies by class. The table presented here is designed to provide a concise comparison of absorption metrics and raw preferences for key antiarrhythmic drug classes. It highlights variability in bioavailability due to factors like first-pass metabolism, impacting clinical utility. Class 1 agents such as flecainide are well absorbed orally, with bioavailability exceeding 90%. Beta blockers like propranolol, however, undergo extensive first-pass metabolism, resulting in variable oral bioavailability ranging from 30% to 50%. Class 3 antiarrhythmic agents, such as amiodarone, exhibit an oral bioavailability ranging between 35% and 65%. In contrast, Class 4 agents, like verapamil, demonstrate a lower bioavailability, typically within the range of 20% to 35%. Intravenous options bypass absorption concerns and are used in acute settings. Distribution. The distribution of antiarrhythmic agents is influenced by protein binding and lipid solubility. Amiodarone, for instance, is highly lipophilic, resulting in extensive tissue distribution and a large volume of distribution, approximately 60 liters per kg. Conversely, digoxin exhibits lower lipid solubility and preferentially distributes in cardiac tissue, with a volume of distribution of 7.3 liters per kg. Metabolism.
Metabolism primarily occurs in the liver, mediated by cytochrome P450 enzymes. Amiodarone is metabolized by CYP3A4, forming active metabolites with long half-lives, necessitating careful dosing adjustments. Class IC agents like flecainide are also extensively metabolized hepatically, whereas sotalol undergoes minimal metabolism and is excreted unchanged.
Excretion. Excretion of antiarrhythmic drugs often involves renal clearance, necessitating dose adjustments and renal impairment.
Sotalol, for instance, is primarily renally excreted, with more than 80% eliminated unchanged in urine. Amiodarone, in contrast, is excreted mainly via biliary and fecal routes, contributing to its prolonged half-life of up to 50 days.
Safety profile of antiarrhythmic drugs. We will start with common side effects of antiarrhythmics. Lidocaine, a Class 1B antiarrhythmic, commonly causes dizziness, drowsiness, and confusion due to its central nervous system effects. Additionally, it may lead to hypotension, especially when administered intravenously in high doses. Common side effects of flecainide include dizziness, blurred vision, palpitations, and nausea.
Beta blockers commonly cause fatigue, dizziness, and bradycardia, as seen with drugs like bisoprolol or metoprolol. These side effects can often be managed by dose adjustments or switching to a beta blocker with a shorter half-life. Class 3 antiarrhythmics, such as amiodarone, frequently cause gastrointestinal upset, including nausea and constipation. Monitoring thyroid and liver function regularly can mitigate these risks by detecting early signs of dysfunction.
Calcium channel blockers, including diltiazem, may lead to peripheral edema and flushing. Elevating the affected limb or switching to an extended-release formulation can provide symptomatic relief. Serious adverse effects. The table presented here is a concise summary of critical adverse effects associated with antiarrhythmic drugs. Amiodarone can cause serious pulmonary toxicity, manifesting as interstitial pneumonitis or pulmonary fibrosis.
Regular pulmonary function tests and imaging are essential for early detection. Sotalol carries a risk of torsades de pointes, especially in patients with electrolyte imbalances or prolonged QT intervals. Continuous ECG monitoring during initiation or dose adjustments helps minimize this risk. Class 1C agents like flecainide may exacerbate arrhythmias in patients with structural heart disease.
Careful patient selection and dose titration are critical to avoid this proarrhythmic effect.
Digoxin, often used in rate control for atrial fibrillation, can lead to toxicity presenting as arrhythmias or visual disturbances, necessitating therapeutic drug monitoring. Adenosine, used acutely to terminate supraventricular tachycardia, may cause transient chest pain or flushing but is generally well tolerated with a rapid onset and offset of action.
Warnings and contraindications.
Amiodarone is contraindicated in patients with severe liver dysfunction due to its extensive hepatic metabolism. In such cases, alternative agents like sotalol may be considered, though it requires renal function monitoring.
Beta blockers should be used cautiously in patients with asthma or COPD, as they can exacerbate bronchospasm.
Additionally, both beta blockers and calcium channel blockers require close monitoring in patients with hepatic or renal impairment, with dose adjustments as necessary.
Safety in pregnancy and lactation.
Amiodarone and flecainide are relatively contraindicated in pregnancy due to potential teratogenic effects, including fetal hypothyroidism and developmental delays. Beta blockers like labetalol are safer alternatives, particularly in managing arrhythmias during pregnancy. In lactation, drugs like propranolol and sotalol are generally safe, given their minimal secretion into breast milk. Amiodarone is contraindicated due to its high lipid solubility and prolonged elimination, which can lead to infant exposure and thyroid dysfunction. It is important to recognize that even medications deemed safe for use during pregnancy and lactation must be administered with caution, under the guidance and supervision of a qualified healthcare professional.
Drug interactions.
Amiodarone interacts with warfarin, heightening bleeding risk by inhibiting CYP2C9 metabolism. Switching to direct oral anticoagulants, DOACs, can reduce this risk while maintaining efficacy. Calcium channel blockers amplify beta blocker effects, causing bradycardia. Alternatives like digoxin may be considered for atrial fibrillation rate control. Class 1 agents like flecainide can interact with digoxin, raising its toxicity risk. Sotalol's proarrhythmic effects increase with hypokalemia, necessitating potassium monitoring.
Quinidine can elevate plasma levels of antiepileptics, requiring dose adjustments. Lidocaine's clearance is slowed by CYP3A4 inhibitors, risking toxicity. Beta blockers combined with class 3 agents may excessively depress cardiac conduction. Lastly, let's explore emerging therapies in the treatment of arrhythmias.
Dronedarone, a novel class 3 agent, provides comparable efficacy to amiodarone but with significantly lower risks of thyroid and pulmonary toxicity, enhancing patient safety. Its shorter half-life enables more consistent dosing, minimizing accumulation-related adverse effects.
Recap.
Now that we've explored the topic of drugs used in arrhythmias, let's take a moment to recap.
We've covered the major classes of antiarrhythmics, including sodium channel blockers, beta blockers, potassium channel blockers, and calcium channel blockers, along with their roles in arrhythmia management. We discussed how these drugs restore normal cardiac rhythm, prevent recurrence, and reduce complications. Additionally, we explored their mechanisms of action and key considerations for initiating therapy in clinical practice. We reviewed common side effects such as bradycardia and dizziness, along with serious adverse effects like proarrhythmia and QT prolongation. We addressed safety in special populations, including pregnant patients, and discussed significant drug interactions. Finally, we looked at emerging therapies, such as newer selective antiarrhythmics such as dronedarone.
In conclusion, understanding the pharmacology of drugs used in arrhythmias is critical for optimizing patient care. These medications play a vital role in rhythm control, improving patient outcomes in both acute and chronic settings. Be sure to check out our next video on diuretics, where we'll explore their mechanisms, indications, and clinical relevance in the management of various cardiovascular conditions. For more in-depth information, refer to Katzung and Trevor's Basic and Clinical Pharmacology, Rang and Dale's Pharmacology, and the latest edition of the British National Formulary, BNF. These trusted resources provide comprehensive insights into pharmacological principles and drug therapy.
Thanks for watching.
If you found this video helpful, don't forget to give it a thumbs up and share it with others.
Subscribe to this channel and hit the notification bell so you never miss an update in the series that we are doing. For more learning resources, check the description below. See you in the next video.